All right, so first of all, welcome. Thank you all for showing up today. Um, we at MPFC are very excited specifically for this topic because healthcare has been such a big part of our organization ever since our inception. So, yeah, without any further ado, we'll go ahead and get started. So, the topic today, as you can see, is getting what you need from your doctor, the healthcare needs of lesbian, gay, bisexual, and transgender veterans. And so just first, a few ground rules. So if you're not already muted, please go ahead and mute yourself. If you do have any questions, you can address them to me through the chat box function throughout the presentation. And that's if you have any like direct questions, any clarification you need on a slide. And at the end, we will have a Q&A. So please hold all of your questions until then. And if you have any very, very specific questions, that you don't think, maybe anybody else in the group might be going through, let's go ahead and you can talk to Michael afterwards. We'll have his contact information, and you can send us an email or him directly if that's the way he wants to do it. So, yeah, so Michael, if you want to go ahead and introduce yourself.
Sure. Thank you very much. I'm Dr. Michael Kauth. I'm a clinical psychologist by training. I've been in the VA for almost 25 years now. And I'm currently one of the two directors for the Lesbian, Gay, Bisexual, and Transgender program, LGBT program, under the umbrella of Office of Patient Care Services. That is the large organization that oversees all clinical services provided within VA. We're a fairly new program. We've only been running since 2012. And our focus is mainly on advising patient care services on best policy and practices for addressing the needs of LGBT veterans and providing training to clinical staff as well. So I'm going to move on to the second slide, hopefully. There we go. You should be seeing in the second slide disclaimers and acknowledgments. No financial disclosures or conflicts of interest to tell you about the views expressed in this presentation are my own and not the Department of Veterans Affairs. And I do want to acknowledge my fellow director in the LGBT program, Jillian Shippard, who is also a psychologist, and she's located in Boston. I'm actually located in Houston. Let's make sure that we're all on the same page. I'm sure you're familiar with the LGBT acronym. And this is actually a very big acronym that encompasses several diverse groups that have in common stigma and discrimination based on sexual and gender minority status. And we use this acronym a lot for convenience, but it tends to imply that there are a lot of similarities across these diverse groups. And while there are some similarities, there are also a number of differences across these groups. I'm going to focus more on the differences in the presentation today. And for example, lesbian, gay, and bisexual people have in common same-sex attractions, and transgender folks have in common gender variance and sometimes a gender identity that differs from their birth sex. We don't know exactly how many LGBT veterans there are or LGBT veterans within the VA system because the VA doesn't routinely collect demographic information on sexual orientation or gender identity. Although that will change in the future, there is a fix in place to have a gender identity demographic field in the next few months, maybe six months down the road. And we've made a request to create a demographic field for sexual orientation identity. And this is important for a number of reasons, as I think you'll see as I go through some of what we know about health disparities based on sexual orientation and gender identity. So while we don't know exactly how many LGBT veterans there are in the VA system, there are some estimates that we can look at. And there's a group called the Williams Institute, which is a nonprofit research policy center that has estimated, based on census data, there are about 1 million gay and lesbian Americans who are veterans, which makes up about 3% of the total veteran population. Separately, they've also estimated that there are about 143,000 transgender veterans. That 3% figure falls within the range that's sometimes reported by convenience samples of Americans who identify their sexual orientation as lesbian, gay, or bisexual, or their gender identity as a transgender or some version of that. Although there are other studies that reported higher prevalence rates, all of these basically are kind of convenient samples that are estimating the actual prevalence. What's interesting about this this data from the Williams Institute and the 1 million figure is those folks who identified as lesbian, gay, or bisexual they're overrepresented by women by 5 times. And that's interesting because women are such a minority within the veteran population. They only make up about 15% of active duty personnel. But lesbian and bisexual women are overrepresented within that group of veterans who identify as non-heterosexual. Again, although we don't know the exact number of transgender veterans in our system, we can look at diagnostic codes if those veterans are getting services related to transgender care. For example, getting cross-sex hormones. And a group of us did just that. We looked at unique veterans with diagnostic codes related to transgender status. And for this particular study, that the relevant code was gender identity disorder. And what we found was a prevalence rate that was actually 5 times higher than what's reported in the general population, which is only 4.3 per 100,000. Now, I believe strongly that 4.3 figure in the general population is a big underestimate. I'm not sure by how much. And I'm certain that our own figure within the VA is an underestimate, although it may be by a smaller margin. We know that there are many veterans who come to us for particular kinds of services, and transgender veterans may come to us for some healthcare needs, but choose to get their transgender-related care, like cross-sex hormones, outside of the VA. Although the VA does support those medications. I think it's also important to remember that while Don't Ask, Don't Tell was repealed, that only affected service members who were gay, lesbian, or bisexual. It did not affect transgender service members, and it is still prohibited for transgender service members to be open about their status. That will lead to their discharge. I mentioned social stigma earlier, and by that I'm referring to bias, prejudice, discrimination, and so on. The consequences of social stigma are stress, anxiety, depression, maladaptive behaviors, trying to deal with those stressors like problem drinking or drug use. Other consequences are also victimization, being targeted for violence. And all of those consequences contribute to poor health outcomes for LGBT individuals, including difficulty accessing care or accessing clinically appropriate care. The idea that minorities within a majority population experience health disparities is known as minority stress theory. And the belief is, and this is actually supported by data, is that ethnic LGBT people experience probably a double dose of minority stress as an ethnic minority, but also as a sexual or gender minority. And ethnic LGBT people may find that they don't get a lot of acceptance from their ethnic community for their either same-sex attraction or transgender status, because those things may be viewed as something foreign or alien to the ethnic culture. And at the same time, ethnic LGBT people may find sometimes not getting a great deal of acceptance and noticeable racism within the larger gay community, which is often characterized as a white gay community. So every day, consciously or unconsciously, an LGBT person may be concerned about, may worry about, or wonder if today I'm going to be stared at or ignored, called names, called by the wrong gender, harassed, told I'm a sinner, hit or have my property vandalized, denied a job or be fired from my job without any legal recourse. Hear politicians claim that people like me don't deserve equal rights. Have citizens within my state vote to deny people like me equal rights. Pay as much or more taxes with fewer state benefits. Be unable to marry my longtime partner, depending on the state in which I live. Be treated disrespectfully by a healthcare provider or even denied healthcare. Now, up till now, we've been talking about kind of the larger culture in which we live, but there's another culture that's important to this population that we're focused on today, and that's military culture. There are a number of reasons why people join the military, sometimes to escape conditions in their life, sometimes for opportunities for advancement in their lives. We often hear that some of the benefits that veterans experience from serving in the military are that sense of structure and mission and the camaraderie of colleagues. And that's often missed when they leave the service. But for the purposes of sexual identity or gender identity, I think it's important to remember that very often people entering the service are quite young, late teens, early 20s, and those folks may not have completely come to terms with who they are sexually. Their sexual identity may not be completely stable, or they may not be aware or have dealt with all of their feelings. While they may be aware of their gender identity, for some that may be an uncomfortable reality. And they're entering a mostly male, ultra-masculine, heterosexist military environment in which, if their sexual feelings are non-heterosexual, at least before the repeal of Don't Ask, Don't Tell, it's necessary for them to hide or deny those feelings and hope that they would change, and may feel a great sense of guilt and shame around those feelings. It may be necessary for them to need to pretend to be straight, to prove that they're heterosexual to avoid detection, or to prove they're a real man or a real woman, or to live in constant fear of discovery. And at least for many of the LGBT veterans that I've worked with clinically, I've certainly noticed a kind of compartmentalization of some of their feelings, particularly around sexuality. That was probably a survival mechanism at the time, of trying to separate off and compartmentalize their sexual feelings, because that would have gotten them into trouble if they were actually expressed. And that habit of kind of separating themselves off from their sexual feelings and who they are as a whole person gets carried over sometimes into civilian life. It's a hard habit to just change because you leave the service. So let's talk about what we know about LGBT veterans, and it's actually quite limited. I'm going to go over in a couple of slides just briefly what the literature says about LGBT veterans. A group of us did a review of what has been published, at least since early 2014. So I'm happy to say that in the last couple of years, there's just been an explosion in the number of research studies in this area. And so I'm really hoping that in the next year or two, as these results get published, we're going to learn a lot more about this population. And indeed, there are a lot of gaps in our knowledge here, as I think you'll see. So let me talk about lesbian and bisexual female veterans first. Actually, the bulk of the literature that has been published is on lesbian and bisexual female veterans, believe it or not. While we were working on our own review, there was another group, unbeknownst to us, that was publishing a review of 11 published studies. And they found compared to heterosexual female veterans, lesbian and bisexual female veterans had much higher rates of physical and sexual violence in childhood and adulthood, higher rates of substance abuse, poor mental health outcomes, and increased suicidal ideation. Another study, a prospective study, that means they followed people over time, of almost 400 Operation Enduring Freedom, Operation Iraqi Freedom women veterans, found that about 10% of that population identified as lesbian or bisexual. And that group had much higher rates of military sexual trauma, also higher rates of substance abuse. Interestingly enough, the lesbian and bisexual female veterans said they plan to use VA services more than heterosexual female veterans. And then a population study looking at data across 10 states found that lesbian and bisexual female veterans were more likely to smoke, again, had poorer mental health outcomes. The smoking thing is really interesting. We see increased rates of smoking across all of these groups, lesbian, bisexual women, gay and bisexual men, transgender folks. And that's, I think, in part because the tobacco industry targeted the LGBT community with ads. May not be the only reason, but that's, I think, an important one. Let me go on here. It may surprise you to know that there isn't a large literature on gay and bisexual male veterans. And that may be surprising because there have been so many HIV studies that have included veteran populations over the years. The VA has participated in a lot of these studies. But most often they characterize the sample based on sexual risk behaviors and not identity. And those studies that took place outside of the VA that have characterized their sample by identities very, very seldom or never assess veteran status. So we know little about this group. There was a population-based study across 10 states looking at data for gay male veterans and found that that population, compared to heterosexual male veterans, had increased rates of asthma, smoking again, more activity limitations, and they were less likely to seek health care due to cost. On the positive side, gay male veterans were more likely to get a flu shot, an HIV test, and less likely to be overweight. And then a very recent internet survey found that gay male veterans compared to heterosexual male veterans had higher rates on screenings of depression, PTSD, and alcohol abuse. There's a very small literature on transgender veterans, although this is growing. A community sample of 141 transgender individuals in the Boston area, and that's actually a big sample, found that 30% of that group were veterans. And the transgender veterans within the sample reported greater VA use compared to veterans in general. That's interesting. And the transgender veterans in the sample had more mental health symptoms being reported than within the general population. So they had poor mental health outcomes compared to the general population. The study that I referred to you earlier about the prevalence rates of transgender veterans in the VA is the second one here. And we also looked in that study at risk of suicidal behaviors. And we found that those veterans with a transgender-related diagnosis had a risk of suicidal behavior 20 times higher than for veterans in general, which is already high compared to the general population. So it's quite serious. And a very recent study looking at all of the identifiable transgender veterans in VA records, more than 5,000, found that Black transgender veterans compared to white transgender veterans had poor physical and mental health outcomes. It's interesting, again, kind of confirming what I was saying earlier about a double dose of minority stress. So what we don't know about LGBT veterans specifically, because there haven't been studies done, then we have to draw upon the larger civilian literature. And there's actually a much bigger literature in this area that we can draw on. And looking at the data for lesbian and bisexual women, they consistently show higher rates of heart disease, obesity, and substance abuse compared to heterosexual women. Again, higher rates of smoking. Lesbian and bisexual women tend to get fewer important health screens like mammograms and pap smears. That may be because they're uncomfortable with talking about these issues and getting those exams. It's probably also likely that the healthcare providers are uncomfortable bringing this up and conducting those exams with this population. Lesbian and bisexual women have higher rates of domestic violence compared to heterosexual women, and they're more often targeted for victimization. And then a very interesting study found that lesbian and bisexual women who are not out are more likely to attempt suicide. Gay and bisexual men compared to heterosexual men also have higher rates of heart disease, higher rates of depression, anxiety, suicide, higher rates of smoking and alcohol use, we've kind of noted before. They also find higher rates of body image disorders and eating disorders among gay and bisexual men compared to heterosexual men. Also higher rates of anal cancer, probably due to HPV exposure. Higher rates of sexually transmitted infections, particularly HIV. And again, higher rates of domestic violence and being targeted for violence. And then transgender people compared to non-transgender people have higher rates of suicide, experiences of trauma and violence, homelessness, substance abuse and alcohol abuse, depression, anxiety, and trans women in particular have higher rates of sexually transmitted infections, particularly HIV. So moving on now, LGBT veterans who leave the service and are transitioning to civilian life have a number of important kind of tasks that are in front of them. Returning to work and school and family, and finding a new or building a new kind of structure in their lives and a new mission in their lives, rather than having one imposed by the military. And that can be a struggle. It can be a big challenge for people in general. But also there may have been long separations from loved ones and from intimate partners. And those relationships need to be rebuilt. And there may need to be some negotiation about sexual agreements. And there may be sexual functioning issues that need to be discussed, or just relationship issues that need to be discussed and worked out as they're figuring out how to be a couple again. There's also an important need to find a healthcare provider who can treat LGBT veterans, both the LGBT part and the veteran part. And that means managing some of the military-related issues that may be coming with that veteran, illnesses or depression, or dealing with post-traumatic stress, or just coping with stress in general, and maladaptive ways that we often cope with stress, like drinking or drug use. And then transgender veterans in particular, who are interested in transitioning, need to find a healthcare provider who will help them get access to cross-sex hormones, and if they desire surgeries, to work towards getting access to surgeries. But there are a number of barriers that LGBT veterans may experience in getting appropriate health care. This first study is now about 15 years old, that at that time, lesbian, gay, and bisexual men and women, 3/4 of them reported perceiving discrimination by healthcare providers. A very recent survey of almost 5,000 LGBT and T individuals reported that more than half had experienced disrespectful treatment by a healthcare provider and not getting the care they needed. I don't think that's an improvement. I'm sure that's not an improvement. Why should healthcare agencies be interested in this? Well, I know from the VA's perspective, we want to be the healthcare provider of choice for all veterans, including LGBT veterans. Now, the VA has some unique barriers to overcome, I think, compared to private healthcare organizations. And let me illustrate that with some data. A group of us did a small study just recently at Oklahoma City VA and the Houston VA, where I'm located. And that study included 200 VA healthcare providers and 58 LGBT veterans. And we asked the veterans, how welcoming is your VA hospital to LGBT veterans? And more than a third reported not welcoming. So that's important. We also asked them if they could rate potential barriers in terms of significance, potential barriers that would keep LGBT veterans from coming to the VA. And we gave them, I think, 15 different barriers. And the #1 rated barrier were hurtful, rejecting experiences within the military. Now, we've always known, because we hear this from veterans, that veterans in general connect the VA with the military. They view us as an extension of the military, although we don't see ourselves that way. And I think this data helps support the idea that LGBT veterans have the same kind of perception. They associate the VA with the military. And this is an interesting quote from a lesbian female in one of the focus groups, kind of highlights this finding. She said, quote, "I look at the VA as an extension of my experience on active duty. At a moment's notice, somebody could come in and just say, 'You're a lesbian, and I'm going to snatch your retirement income from you right now and all of your benefits.' And it would be gone just like that." And I think this is a carryover from the long history of bans on homosexuality within the military and don't ask, don't tell, that if they're outed, these veterans are going to be punished for their LGBT and T identity. So why is having a good communication with your healthcare provider important? Well, there's a long, actually big literature that shows that good patient-provider communication leads to greater satisfaction with treatment and better health outcomes for patients. We know without a doubt that sexual orientation and gender identity have significant effects on people's health. And we also know very clearly that few providers routinely ask about sexual orientation or gender identity. And they give a lot of reasons why they don't ask about this. And I think a great deal of it has to do with their own discomfort and not being trained in how to ask questions in these areas appropriately, or why this is even connected to health. But the literature also shows that health discussions about sexual orientation and gender identity lead to more routine health screens and more sexually transmitted infection testing when appropriate, and more tailored recommendations for patients and greater patient satisfaction with the care that they're getting. So that's definitely the direction that we want to go in. How can you communicate more effectively with your provider? Well, I've got 7 different tips here that I'm going to go over with you. I'll go over each one in detail, but the first is do some homework, know a little bit about who you're going to see and get good recommendations if possible. Know your rights and if possible, know the policies and practices of the healthcare agency that you're going to. Become more knowledgeable about yourself, about health issues for LGBT or T veterans, whatever the case may be, because you may need to do some education with your doctor. They may not be well informed. Pay attention to first impressions and your experience. You want to be in a welcoming clinical environment. And address heterosexist language or biased assumptions when they come up with your healthcare provider. And I give an example here of how relationships are portrayed on an intake form, and I'll get more specific about that in a few slides. Ask for what you need and understand what you get. And lastly, give feedback to your healthcare provider. Let's go over each of these quickly. Do your homework. If possible, get recommendations from friends or LGBT-friendly healthcare providers who can maybe direct you to somebody in your area who would be good to see. Ask community centers if you have an LGBT community center in your area. And there are a few websites like this one, the Gay Lesbian Medical Association website, that has a Find a Provider feature on it. And this is not the only one, but it can be a useful way to find providers who are LGBT friendly. When you've identified someone, you might want to call that practice and ask some questions of that practice. And you don't have to give your name over the phone. You might ask that practice if they see LGBT patients, and how do they know that they see them, and things like that. They might ask for to know where the practice is reviewed, if there's a site where reviews are posted from patients to get health care from the provider or the agency. You might consider bringing a friend or your partner to the appointment if you have some concerns about how you may be treated. Certainly bring up sexual orientation or gender identity related issues with your provider early on in the appointment. Do it before you are asked to take off your clothes for an exam, because you're going to be much more comfortable bringing this up early than later when you're in a more vulnerable position. Know what to ask about. Know what are important LGBT-related health issues. And I give you a website here, the Human Rights Campaign website, where you can find more information about talking to your doctor. I think it's important to be knowledgeable about what your rights are. And the American Medical Association has actually issued several policies related to sexual orientation and gender identity. And it may be useful to know that, or comforting. Here's one of the policies that the American Medical Association states explicitly that they oppose discrimination based on a number of characteristics, including sexual orientation and gender identity. Another policy saying that physicians who offer services to the public may not decline to provide those services to patients based on a number of characteristics, including sexual orientation and gender identity. And lastly, a third policy saying that physicians should be non-judgmental about people who are non-heterosexual in terms of their identity and behavior. The VA also has some policies that address these populations. VA has a national visitation policy, which has an inclusive definition of family. This really is anybody that the veteran identifies as someone close to them, important to them, anybody. The VA has a non-discrimination policy for the patients that we see and for the employees that work within the agency that both make reference to sexual orientation, gender identity, and gender expression. The VA has a directive on transgender care that first came out in 2011. We reissued it in 2013 with an appendix that gave more information about how the policy should be applied. And the policy says the VA will provide a number of services to transgender veterans, including gender counseling, evaluations for cross-sex hormones, hormone therapy, evaluations for pre-surgical interventions, sex reassignment, surgical procedures, and also post-surgical care following sex reassignment procedures. VA does not currently provide any of those sex reassignment surgeries. And then last year, the Undersecretary for Health issued an information letter on health care for lesbian, gay, and bisexual veterans. And in VA language, this is a pre-policy statement. This is a heads up to clinicians in the VA that this is an important area of health concern, and there will be a policy that follows this, and we are working on that policy now. Ways you can become more knowledgeable. I have here a page from a website on the Human Rights Campaign site about talking to your healthcare provider, and they have some great tips about how you can better communicate with your healthcare provider. I strongly recommend reviewing that in detail. Also, the Gay Lesbian Medical Association website have these downloadable fact sheets that I think are really cool. 10 things lesbians should talk to their healthcare provider about, or gay men or transgender people. And you can print these off and bring them to your healthcare provider and read them with your healthcare provider so they can become more knowledgeable. So if you reveal to your healthcare provider that you are lesbian, gay, bisexual, or a transgender person, you could expect then to get follow-up questions. And if you're a lesbian, bisexual female veteran, they're probably going to ask you then further follow-up questions about depression and social support and childhood abuse or military sexual trauma, smoking, obesity, and your exercise regimen, as well as questions about military-related illnesses, injuries, or stressors. And if you're a gay and bisexual male veteran, then they should then follow up with questions about level of depression and anxiety and stress, social support, smoking, problem drinking, safer sex practices, exposure to violence, as well as military-related injuries, illnesses, and stressors. And again, if you're a transgender person, you can expect follow-up questions related to then depression, anxiety, social support, suicidal ideation, problem drinking, use of injected silicone, a very dangerous practice, safer sex practices, especially for trans women, and military-related injuries, illnesses, and stressors. Let's move on to first impressions and experience. When you go to a new healthcare provider, what signs and signals are in the environment that tell you that this is a friendly place for LGBT people? What pictures or images are on the wall that might tell you that this is a friendly place? Are there only heterosexual couples portrayed, or couples or people at all? Very often in waiting rooms of healthcare providers, I just see images of scenic landscapes, and that's fine. What magazines are on the coffee table in front of you? Is it Modern Bride, or in my community in Houston, Outsmart, which is the gay lesbian community magazine? If there are community resources advertised within the waiting room or in the clinic exam room for services found within the community, any kinds of services, support groups, AA groups, and so on, are any of those LGBT-related resources? What kind of greeting did you receive from the staff? How comfortable do the staff seem with you? And what questions are there on the intake form that may reveal that they expect to see people like you in this practice? And within the VA, we have a number of signs, posters specifically, that we have encouraged facilities to post that advertise that we are and hope to be an LGBT-friendly place for veterans. This is one of the first posters that we issued in 2013. I like this one a lot, and it's been very, very popular. We followed that up with this poster on assessing sexual health and paid homage to the We Serve All Who Serve poster by putting it on the iPad that the provider is holding there. And then this was a very recent poster that we put out for LGBT Health Awareness Week in March of this year. And it had more than 1,400 downloads from our SharePoint site and internal website to the VA, which was quite remarkable that it was getting that much exposure. I didn't have time to show you the brand new poster that just came out at Friday of last week to commemorate LGBT Pride Month within VA. The LGBT program and Women's Health collaboratively put out a poster that is very, very cool, that has now gone out to all facilities with the encouragement that they print and post these posters in waiting areas. Let's move on to addressing heterosexist language and assumptions. Very often questions on intake forms or questions in the intake exam are biased towards heterosexuals that communicate that we don't expect to see people who are non-heterosexual here. And it's important to call providers on that. When I go to a new provider and I get that intake form that asks about marriage before I was married, I would make corrections, and I would write in the information that I wanted my provider to know and change the form for them. I know not everybody's going to do that, but I do, and I call it to the provider's attention. Now, increasingly, the question, are you married, is less heterosexist if you are in a state that recognizes same-sex marriage. In Texas, Texas does not recognize same-sex marriage. However, if the real issue is to assess relationship status, a much better question is, what is your relationship status? Or do you have a significant person in your life? Are you romantically involved with someone, and who? And offering a number of different options like you see here on the screen: single, married, domestic partnership, partnered, multiple partners, and so on. Get a much richer set of information. And you communicate then, the provider communicates, that they expect to see a diverse set of folks coming into the practice. It's important to remember that sexual orientation identity is different from attraction and sexual behavior. Asking about identity is a very important question. For example, how do you identify your sexual orientation or sexuality? And providers should say something like, I ask this of all of my patients, and do ask that of all of their patients. And these are some common recommended responses that might be offered. The provider should also be able to tell you why this information is important. It's important because people who identify their sexuality as non-heterosexual tend to experience certain health disparities that may need some follow-up questions if that is your identity. Depending on the nature of the clinic visit, that provider may need to ask about sexual behavior, including partners and sexual history. Like, are your current partners men, women, or both? Or in the past, have your sexual partners been men, women, or both? Have you or your partner had additional partners in the last 12 months? Have you ever been treated for a sexually transmitted infection? When was your last HIV test? Are you having any sexual problems or concerns? And if non-monogamous behavior is the norm, or the person may not be willing to use condoms with an HIV partner, have you considered pre-exposure prophylaxis, or PrEP? As a patient, it's important to be clear about what you want, what the issues are that you're having, and about what you want, and to understand what you're getting. So be clear about your main goal for the clinic visit. And I think it's critical to have only one or two issues ready to discuss with your doctor. If it's more than a couple of issues, the doctor is going to consider that too much to deal with for one visit, and that really needs a follow-up visit. And they only have a small amount of time for each patient. To not forget what it is you want to talk about, write it down and bring it on a piece of paper. Be very open about the onset of the problem that you're there to talk about, the symptoms you may be having, the severity, so the provider can make the best diagnosis and the best recommendation for treatment. That's only going to help you. It may be embarrassing, but the provider is really most interested in making the best assessment possible to make the best recommendation possible, not judging you. Get the important stuff out early. Don't save it for the end, even if it's embarrassing. So don't wait until the visit is almost ending or you're walking out the door to bring up the really important stuff. Do it right off the bat. And then ask questions. Make sure that you understand what the provider has said to you. So rephrase it, repeat it back, and ask if that's what the provider meant. And lastly, provide some feedback to the provider about the experience. If you were unhappy, if you were uncomfortable, you might want to say something to that provider and give them some feedback. If you don't feel comfortable doing it face-to-face, increasingly, people are providing online reviews of their healthcare provider. There's some caution with this. This is not like a restaurant review on Yelp. Don't write it like a restaurant review. This is important information and a review that will live for a long time and that others will use to make important health-related decisions. So it's important to do it with a cool head and calmly and to be accurate. If there's something that was really, really troublesome, it may need more than just a bad review. It may be better to follow up by contacting the medical examiner's board or so on to get that problem addressed. And I believe that's the last slide. So let me stop there and see if there are questions from all of you. I did want to leave you with contact information. Either of these addresses will come to me, and I will respond to all questions presented.
All right. Thank you so much, Michael. It was a wonderful presentation, and I'm sure it's going to help out a lot of people. And very excited the work that you're doing there at the VA. So, yeah, thank you for donating your time and talents to us. And with that, we'll go ahead and get started. Meg, do you want to start off asking your question?
Yeah, I actually posted all the questions on the chat, and because I just had so many, and that was the.
Okay.
And I thought it would be better if you guys could see it. So.
I saw there was stuff here, but I couldn't read it while I was talking. Let me see if I can get through here.
Yeah, so I'll start off. I'll just ask you, Michael. So is the VA actively
Sure.
trying to create a safe space for LGBT vets? Was the first question. I think we saw that a little bit in these previous slides with the posters you guys are making and all that kind of stuff. But is there any further work that's being done to really, change the intake forms and all that other kind of stuff?
Yes, yes, there is, and we are actively trying to create a safer space and a more friendly environment for LGBT veterans. And this requires, multiple strategies to make this happen. It's a complex healthcare system with lots, 151, 53 medical centers and about 800 outpatient clinics across the system, with lots of providers to contact. So it's a huge task to do, but we're doing this through a number of different ways, providing clinical training repeatedly throughout the year, these awareness posters that reach people in a slightly different way. We really target those posters to clinicians because we're tasked with doing clinician training, but we know that those posters are also going to be seen by veterans, which we think is a plus. That's a very important thing. So yeah, there is active ongoing training. We are working towards getting LGBT cultural competency training into the mandatory yearly training that everybody does, where we haven't gotten there yet because it's just a small set of trainings that VA has prioritized that everyone should get once a year. We think this is important, and so we're arguing that we should be part of that small group of annual trainings.
Awesome. And I think that actually answers another question. Next, we have a question from Ariana. Is there a plan for the VA to begin offering gender-affirming surgeries in the near future? And what would need to happen for that? And also, do you guys recruit physicians with those skill set, or do you train current physicians?
Good, multiple questions. We do have transgender veterans in the system, and we are treating them, and we are providing training for those providers. And we're doing it in a couple of ways. There are some, national didactic trainings that are available on the VA's web-based educational platform that all of us can access. We actually have 3 really cool trainings on transgender care, an introduction program that's appropriate for all staff, including non-clinical staff, one for mental health providers on conducting evaluations for cross-sex hormones, and one on prescribing cross-sex hormones. The cool thing about all 3 of those is we've embedded video from transgender veterans who talk about their healthcare experiences, some in the VA, some outside of the VA, and what they want VA providers to know about treating people like them. They're really, really powerful. We've also got some video demonstrations of bad staff interactions with transgender veterans and some positive, constructive interactions with transgender veterans that we show as examples of what people should be doing. So yes, we are offering training. We do have some surgeons who are working within the VA who in their private practice or in their university practices also do sex reassignment surgeries. We don't do those surgeries in the VA, but we do many surgeries that are close. I'm not sure I would say comparable, but sometimes it involves genital reconstruction. We get a number of veterans who've had blast injuries that have damaged their genitals, and those need to be repaired, or there are complications after the initial surgeries, and that needs to be repaired. And VA does mastectomies, breast reductions. The VA does orchiectomies, removal of testicles for various reasons, but not for transition-related care. The VA doesn't provide these services because of a regulation that prohibits VA funding for gender alteration. That's the phrase that's used. This was a regulation that was enacted in 1992. It was not defined then or now, although there's a kind of common interpretation that we have lived with for a number of years, that this doesn't include or it prohibits sex reassignment surgeries. Like all of our regulations, we review whether those regulations are consistent with current medical knowledge. And if you've been following the news, you probably know that there is there's been a kind of a birth or explosion of studies that have come out in the last 10 years that have been supporting transition-related surgeries. And just last year, I believe it was a year ago, the Center for Medicaid and Medicare Services issued a ruling that they would no longer prohibit sex reassignment surgeries. That would now be allowable. Doesn't mean everyone would get them, but there would no longer be a prohibition. Still needs to be based on the appropriate medical evaluation and a decision by a healthcare provider. So that certainly is the way I think the nation is moving. There are other health insurers that are now offering transition-related surgeries. If you are a member of Congress and you get your health care through the DC Exchange, and a number do, the DC Healthcare Exchange offers transition-related surgeries as one of the benefits. And just last year, the Office of Personnel Management that oversees the available health insurers for federal employees who get insurance through the federal system, they allowed insurers to offer the benefit of transition-related surgery. So there are now federal employees who get their health care through the federal system may have insurers who offer these benefits, and some of those may be veterans, federal employees. So I can't tell you that this will happen or when it will happen, but I think you see where the trend is going.
Awesome. So the next one, if you can open up your chat, because there's several questions from Meg. And actually, Meg, as he looks at those, if you want to go ahead and explain your questions, I don't want to kind of summarize for you.
Yeah, one was non-trans specific. It was more if anyone was aware of any developments in adding HPV, any medical developments in adding HPV screenings to an STI panel, because as some people may know, HPV is the most prevalent STI out there for which there is actually no screening in men. So unfortunately, the term disease-free may actually be a misnomer.
Yeah, I don't know that this is, I know it's not being done routinely, and we are trying to raise awareness of the need for HPV screening in men as well.
Okay.
I see a question here about intake forms to allow patients to identify how they wish to be addressed. I don't know that this is, certainly yes, we're encouraging people to change their intake forms to note this, to have gender identity as well as birth sex in the form and sexual orientation identity. We can encourage it. We can't require that they do this. In the training that we provide to clinicians, we encourage clinicians to ask these questions, at least in their clinic visit. Part of our policy is that veterans will be addressed by the name and the gender that they prefer, and this will be noted in the record. At present, we don't have a demographic field that allows other providers to see what that preference is. We will at least have a gender identity field in about 6 months. That'll be helpful, but we don't have a preferred name field yet. Okay.
I was also wondering, and this probably goes off of Kim's latest question as well, but it's great that there's, the option to go ahead and put up these posters. Is it going to be a mandate? And so let's say someone sees these posters, a veteran comes in, sees these posters, says, okay, I'm going to come in, get my healthcare needs met, but then the first person they meet, the gatekeeper, may not be the actual healthcare provider itself, but maybe the gatekeeper may have an attitude, may not be quite so welcoming. What are the self-policing, what's the recourse against that?
Yeah.
What is done within the VA to address that so that there is a consensus of, good and positive medical care?
Yeah. Well, you're very right. The first people that the veteran encounters when they come to the facility is not a healthcare provider. It may be the valet. It may be the maintenance worker or the person sweeping the floors, and eventually a clerk, eligibility clerk or a clinic clerk before they ever reach a healthcare provider. And those are very important people within the system. And we want those experiences to be positive. Will they always be positive? No, they probably won't be. Will every clinic visit be positive? Probably not. But we are working to move towards that. And these posters, when they're posted throughout the facility, or facilities participate in pride events, that communicates something to all VA employees, that this is important. All VA employees are also made aware that the VA has non-discrimination policies that are focused on veterans and what those non-discriminatory characteristics are. And if there's an incident that occurs, the veteran has some recourse. They can go to the patient advocate and make a complaint about the experience that they had. And those are taken seriously. The patient advocate reports directly to the medical center director in the organizational structure. So the medical center director at those facilities knows that there's a problem and is required to address that. But providing training doesn't mean that discriminatory experiences will never, ever happen.
Right.
We don't live in that kind of ideal world.
Thank you.
Sure.
All right. Do we have any other questions?
All of your questions? Yeah, let me. Or any? Let me talk a little bit about the idea of mandatory training, because even within the VA, often people think that that's the best solution. I'm not convinced it's the best solution, and I can tell you that just requiring that everybody do a training doesn't necessarily mean that that training is experienced in the way that it should be. Often, and you may find this to be true in your organizations, when you're told that you're required to do something, there may be a reaction among staff to being told that you have to do this. And mandatory training is sometimes treated as something that is not so desirable to do, or something that you just try to get through as quickly as possible so you can move on to your real work. And it should be valued. And we actually, though, get a very strong positive reaction from the training that we put out to folks. And we've identified, not sure what the right term is, but enthusiastic ground troops at our facilities, most of our facilities, who are very eager to get new information about LGBT veteran issues and to communicate that through their own channels at their facility to other employees. And so we can push things down at a top level, down through the system. But another way of approaching education, and maybe a more powerful way in some respects, is that kind of ground up. When information is coming to you from people in your own facility, or at a horizontal level, it's often viewed differently and sometimes more legitimately. We want to use all of those strategies again to get information out.
All right. Well, thank you all for your questions, and thank you again, Michael. This was wonderful.
Sure. My pleasure. I really appreciate the chance to talk with all of you.
All right. Well, thank you again. And everybody, if you do need to get a hold of Michael, his contact information is there. And as always, you can get a hold of me if you have any questions about this. And my email is just colin@mpfc.org. So, yeah, and you can get a hold of us through our Facebook page as well. So thank you again. Have a wonderful day, everyone.
Thank you.
Thank you.